Welcome to the Deep Dive. We're here to help you get that elite understanding of really complex topics fast. Today, we're jumping right into something tough in pharmacology: antifungal drugs. It's a tricky area. Our goal: to cut through the dense clinical info and give you the absolute core knowledge. We're talking mechanisms, how the body handles these drugs, and crucially, those dangerous interactions you have to know.
Yeah, fungal infections, mycoses, they're just notoriously hard to treat, often chronic. And the drugs themselves, well, they come with risks. It's not like bacteria where you have lots of clear targets. With fungi, the big problem is they're eukaryotic.
Eukaryotic,
Yeah,
like our own cells.
exactly. And that similarity, it seriously limits our options for safe targets. Hitting the fungus without hitting the patient, that's the challenge.
Okay, so if our basic cell machinery is similar, what are those key differences, the ones we can actually target with drugs?
Right. There are essentially three main structural differences that define our drug classes. First up, the fungal cell wall. It's rigid, made mostly of chitin.
Chitin, we don't have that.
Nope. So the cell wall is a great, unique target. Then second, and this is central for many classic drugs, you have the fungal cell membrane. It uses ergosterol.
Instead of cholesterol, which we use.
Precisely, ergosterol. Functionally similar maybe, but structurally different enough for drugs like polyenes and azoles to exploit. So chitin in the wall, ergosterol in the membrane, those are the big differentiators. And knowing this stuff is becoming more and more critical, right? The sources are clear. Serious fungal infections, things like candidemia, are on the rise.
Absolutely. This isn't just theory, it's everyday clinical practice. And the reason it's rising, well, it's kind of a consequence of medical progress. We have more patients who are chronically immune suppressed. Think organ transplants, intensive chemo, advanced HIV.
Expenses are down.
Exactly. And that gives opportunistic fungi a chance. So clinicians really need this advanced knowledge, how the drugs work, how to manage the toxicity. So to really master this, we've structured today's deep dive. First, we'll tackle the big guns for systemic infections: the polyenes, powerful but toxic, and their partner, the antimetabolites. Then we'll spend a good chunk of time on the azoles. That's where drug interactions are absolutely make or break. And finally, the newer cell wall agents, the Echinocandins, and then the drugs for skin and male stuff. Sound good?
Sounds like a plan. Let's dive in. Okay, let's start with the classic, the really potent one, Amphotericin B. Sometimes called amphoterrible because of the side effects, right? Yes, it has that reputation. But despite the toxicity, it's still the go-to for many really life-threatening fungal infections. It's produced by Streptomyces nodosus, actually.
So why use it if it's so toxic? What makes it worth the risk?
Pure efficacy against some really nasty bugs. We're talking Candida albicans, histoplasma, crypto, coccidioids, blastomyces, even many aspergillus strains. For those, sometimes, it's the best weapon we have. High risk, high reward, definitely.
And its mechanism. It's called the pore former. That sounds pretty direct. How does it use ergosterol to kill the fungus?
It's quite direct, yeah. Amphotericin B molecules, they have parts that like water and parts that hate water amphipathic. They basically wedge themselves into the fungal membrane by binding to ergosterol.
Okay, they bind to the ergosterol.
And once enough of them bind, they sort of cluster together and form these channels, these pores, right through the membrane.
Pores. So stuff just leaks out.
Exactly. The membrane integrity is gone. You get this massive leakage of electrolytes, especially potassium, and other small molecules just pouring out.
The potassium loss. That comes up a lot with its toxicity.
It's central. This loss disrupts everything: osmotic balance, electrical gradients. It basically leads to cell lysis, cell death. So it's fungicidal, usually.
And interestingly, it's also used for leishmaniasis, a protozoal infection.
Yeah, it highlights that sterile-dependent membranes aren't unique just to fungi among non-mammalian eukaryotes. But let's pivot to managing that toxicity, the pharmacokinetics. This is crucial.
Right. It doesn't dissolve in water, so it needs a slow IV infusion. And the formulations have changed, haven't they? From conventional to lipid-based.
Yes, and that change was huge clinically. The original conventional form uses sodium deoxycholate to dissolve it. But the problem is it delivers the drug everywhere, binding to our own cholesterol-containing membranes, too. That's where the toxicity comes from.
So the liposomal versions,
Yeah.
they package it differently.
Exactly. They encapsulate the amphotericin B inside tiny lipid bubbles, liposomes. These tend to deposit the drug more selectively at the site of infection, like inflamed tissue, and get taken up by immune cells. This means less drug floating around hitting the kidneys, for example.
So definitely worth the extra cost for that reduced kidney and infusion toxicity.
Oh, absolutely. It significantly improves the safety margin. It really changed how we could use the drug. Okay, let's break down those toxicities. First, the immediate one. The shake and bake infusion reactions. Yeah, with the conventional formulation, these are almost guaranteed. Usually starts 1 to 3 hours after the infusion begins. High fever, really intense shaking chills, rigors, nausea, headache. It's miserable for the patient.
How do you manage that?
It tends to lessen with repeated doses, but pre-medication is key. Usually acetaminophen, maybe an antihistamine, sometimes even a low-dose corticosteroid before the infusion helps blunt that reaction. Then the big one, kidney damage. Nephrotoxicity. How does Ampho B actually damage the kidneys? It hits the kidneys in a couple of ways. It can constrict the blood vessels there, reducing the filtration rate, the GFR. But more importantly, it directly damages the kidney tubule cells.
And the damage leads to
problems reabsorbing things. So you see serum creatinine levels rise, and you get significant electrolyte wasting, especially potassium and magnesium loss, hypokalemia, hypomagnesemia. And at high cumulative doses, some of that damage can be permanent.
Scary stuff.
Yeah.
So mastering this drug means mastering how to protect the kidneys. What are the strategies?
First, hydration. Keep the patient well hydrated. Second, for the conventional form, sodium loading is vital. Giving normal saline before the Ampho B infusion helps protect the tubules.
Sodium loading. Interesting.
Yeah, it counteracts some of the drug's negative effects there. But the best strategy, if possible, is just using the liposomal formulation. And critically, you have to watch out for other nephrotoxic drugs.
Like amyloglycosides or vancomycin?
Exactly. Adding Ampho B on top of those, that's asking for serious kidney trouble. Avoid it if you can.
Okay, and the other risks. You mentioned low blood pressure and vein issues.
Right. Hypotension can happen, sometimes a shock-like drop in pressure, often linked to that potassium loss. So you need to monitor potassium closely and replace it aggressively if needed, which is extra tricky if the patient's also on digoxin, where potassium levels are critical.
And thrombophlebitis.
Yeah, inflammation at the IV site. That's usually managed pretty easily by adding a little heparin to the infusion itself.
All right, that's Amphotericin B. Powerful, risky, needs careful handling. Now what about its partner, Flucytosine or 5-FC, the antimetabolite?
Right, 5-FC. It's rarely, if ever, used alone. It's a synthetic pyrimidine antimetabolite, and its real strength is its selective toxicity mechanism. It's mostly fungistatic.
How does it achieve that selectivity? It relies on an enzyme only the fungus has.
Yeah.
Cytosine-specific permease. Think of it as a specific doorway into the fungal cell. Our cells don't have that doorway.
Nope. So the drug primarily gets into the fungal cells, not ours. That's key.
And once it's inside, what does it sabotage?
Once inside, the fungus itself converts 5-FC into 5-fluorosil, or 5-FU. This 5-FU then gets processed into other nasty compounds that basically mess up nucleic acid synthesis. Specifically, it blocks the production of DTMP, which is essential for making DNA, and it also interferes with protein synthesis.
So it gums up the works for DNA and protein production.
Pretty much, it stops the fungus from replicating effectively.
And you said it's not used alone? Its clinical use depends on synergy with amphotericin B?
Absolutely. Resistance to 5-FC pops up really fast if you use it alone. The fungi mutate the permease or the converting enzymes. But when you use it with amphotericin B,
the pores from Ampho B let more 5-FC in.
Exactly. Ampho B punches holes in the membrane, creating wider entry points for 5-FC. This floods the fungal cell with much higher concentrations of 5-FC than it could normally take up, dramatically boosting the effect. Real synergy.
Where is this combo most important?
It's crucial for serious systemic infections, especially fungal meningitis caused by Cryptococcus neoformans or Candida albicans. A huge advantage of 5-FC is that it's taken orally and gets excellent penetration into the cerebrospinal fluid, the CSF.
Ah, CSF penetration is vital for meningitis.
Definitely. Makes it invaluable there. Also sometimes used for Candida UTIs if fluconazole isn't an option.
Okay, what's the main thing to watch out for with its pharmacokinetics and safety?
The kidneys. It's almost entirely cleared by the kidneys through glomerular filtration unchanged. So if a patient has any kidney impairment, you absolutely must adjust the dose down.
And if you don't, you risk its main toxicity. Dose-related bone marrow suppression. That means neutropenia, low white blood cells, and thrombocytopenia, low platelets. Serious stuff. Why does it hit the bone marrow if our cells don't take it up well?
That's a good question. It's thought that maybe some of the 5-FC gets converted to the toxic 5-FU by bacteria in our gut. That 5-FU then gets absorbed and hits rapidly dividing cells like those in the bone marrow and the GI tract.
The gut-bacteria connection.
Yeah. So besides bone marrow issues, you can also see liver problems, usually reversible, and GI side effects like nausea, vomiting, even severe gut inflammation and enterocolitis.
All right, we've tackled the membrane disruptors. Now we enter the vast territory of the azoles. This is the biggest class, right? And they target ergosterol differently.
They do. Instead of poking holes in the membrane, azoles block the synthesis of ergosterol. It's a huge class. We generally split them into the older imidazoles like clotrimazole, ketoconazole, mostly used topically now.
And the newer triazoles.
Right, the triazoles fluconazole, itraconazole, voriconazole, postconazole, ezovuconazole. These are the systemic workhorses for treating and preventing deep fungal infections. But this is where drug interactions become a minefield.
Okay, let's nail down their general mechanism first. How do they stop ergosterol production? They're mostly fungistatic, meaning they stop growth rather than kill directly. They work by inhibiting a specific fungal enzyme, 14-alpha-demethylase. 14-alpha-demethylase.
It's a type of cytochrome P450 enzyme, a fungal CYP enzyme. It's crucial for converting lanosterol into ergosterol. Block that enzyme, you starve the membrane of ergosterol, it loses integrity, and you also get a buildup of toxic precursors, halts fungal growth.
Makes sense. But we keep hearing about azole resistance. How big a problem is that?
It's a major clinical headache, especially in immunocompromised patients getting long-term treatment. The fungi are clever. They can mutate that target enzyme, the 14-alpha-demethylase, so the azole doesn't bind as well.
Okay, mutation is one way.
Another big one is efflux pumps. The fungus basically installs pumps in its membrane to actively push the azole drug back out as fast as it comes in.
Wow. So it just pumps the drug away.
Yeah. And some fungi can even change their membrane composition to need less ergosterol altogether. Very adaptable. Before we get into the specific drugs, we have to address the elephant in the room. Those CYP450 drug interactions. You said it's a minefield. This is absolutely critical. If you take one thing away about azoles, it's this. Nearly all azoles inhibit the human hepatic enzyme, CYP450, 3A4.
3A4, the one that metabolizes what, like half of all DRA?
Something like that, yeah. It's the major highway for drug metabolism. So if you give an azole which blocks this highway, any other drug the patient is taking that uses this highway will get backed up. Its levels rise.
Leading to increased side effects or toxicity from that other drug.
Exactly, at potentially dangerously high levels. And it gets even more complex.
How so?
Because many azoles, like itraconazole and voriconazole, are not only inhibitors of CYP enzymes, they're also metabolized by them.
Okay, wait. So they block the enzymes, and they're also processed by the enzymes. Yes. So think about it. If you give a drug that inhibits CYPs, like ritonavir, it can dangerously increase the azole levels, causing azole toxicity. But if you give a drug that induces CYPs, makes the liver produce more enzymes, like radimpin or phenytoin, it chews up the azole faster.
Right, leading to low azole levels and potentially catastrophic treatment failure. The fungus wins.
This sounds incredibly complex to manage. The sources list some specific life-threatening interactions. Can we highlight those?
Yeah, these are absolute no-nos or require extreme caution.
QT prolongation. Azoles can dramatically increase levels of drugs that prolong the heart's QT interval, amiodarone, pemazide, others. That risks fatal arrhythmias like Torsades de Pointe.
Okay, heart rhythm dangers. What else?
Statins and rhabdomyolysis. Combine a strong azole, like itraconazole, with simvastatin or atorvastatin, both 3A4 substrates, and the statin levels skyrocket. Huge risk of severe muscle breakdown, rhabdo, which can trash the kidneys. Very common, very dangerous if missed.
Muscle breakdown, scary. Third.
Neurotoxicity. Using azoles with certain chemo drugs, like the vinca alkaloids vincristine, vinblastine can boost the chemo levels way up, causing severe nerve damage.
And fourth.
Immunosuppressant toxicity. Crucial for transplant patients. Azoles significantly raise levels of drugs like sirolimus or cyclosporine. You have to cut the immunosuppressant dose way down to avoid major toxicity like kidney damage.
Wow. Okay. It really drives home the point that sometimes for a patient on many interacting meds, an azole might just be too risky interaction-wise.
Absolutely. That's often when you reach for an echinocandin instead, which we'll get to. Managing that interaction profile, the advanced skill here. One more general point on azoles. Pregnancy. Generally considered teratogenic, harmful to the fetus. Avoided in pregnancy unless the fungal infection itself is a greater threat to the mother's life. Risk versus benefit calculation.
Okay, let's dive into the specific systemic triazoles. Each has its own personality, right? Let's start with fluconazole.
Fluconazole. It's kind of the oldest of the main systemic triazoles and the least active in terms of spectrum. It's mainly good against yeasts, Candida albicans, Candida parapsilosis.
But not the serious molds.
Right. Critically, it has no useful activity against Aspergillus or the Zygomycetes. That's a major limitation. But it's the drug of choice for things like maintenance therapy for cryptomeningitis after Ampho B, and it's the standard single-dose oral treatment for vaginal yeast infections.
What about its pharmacokinetics? Is it easier to handle?
Yes, that's its main advantage. It's well absorbed orally, gets into tissues well, including really good CSF penetration. And the unique part, most of it, over 80%, is excreted unchanged by the kidneys.
So kidney function is key.
Absolutely. Great for Candida UTIs because it concentrates in the urine, but you must adjust the dose if kidney function is poor. Compared to other azoles, its CYP inhibition is relatively weaker, more 2C90, 2C19, less 3A4, and side effects are usually milder nausea, headache, rash.
Okay, moving on to Echinocandins, used for more serious endemic fungi.
Yeah, Echinocandins has a broader spectrum. It's the drug of choice for several dimorphic fungi, common in the Americas: blastomycosis, histoplasmosis, sporotrichosis, paracocadioidomycosis. But its pharmacokinetics, they're notoriously tricky.
Tricky how? Tell us about the absorption issue.
This is a classic point of failure if not managed. The capsule or tablet form needs stomach acid to dissolve, so it must be taken with food or an acidic drink like cola. But the oral solution form is different. It needs to be taken on an empty stomach because food actually decreases its absorption.
Wow, complete opposites depending on the form. Easy to get wrong.
Very easy. Get it wrong, and the drug levels might be too low to work.
And Echinocandins has a major heart-related warning, doesn't it?
Yes. This is non-negotiable. Itraconazole has a negative inotropic effect. It weakens the heart muscles contraction. Because of this, it is absolutely contraindicated in patients with heart failure or other forms of ventricular dysfunction. It can trigger or worsen heart failure. Major black box warning.
Got it. No Echinocandins in heart failure patients. Next up, posaconazole. Even broader spectrum. Posaconazole is very broad, similar to itraconazole, but with crucial added activity against some really tough molds, like Cetosporium and, importantly, the Zygomycetes, the ones that cause mucormycosis. So it's used a lot for prevention and treatment in very high-risk, severely immunocompromised patients.
How's its PK?
Still tricky.
Still tricky absorption, yeah. Low bioavailability overall, needs to be taken with a high-fat meal to get decent levels. And just like itraconazole, drugs that reduce stomach acid PPIs, H2 blockers, will really hurt its absorption. Must be careful there.
And its metabolism. Is it different?
Yes, this is unique. Posaconazole isn't metabolized by the CYP450 system. It's eliminated mainly by glucuronidation, so it's not affected by CYP inducers or inhibitors. However,
it still inhibits CYP3A4.
Yes, it's still a potent inhibitor of 3A4. So while its own levels are stable regarding CYPs, it could still dangerously increase the levels of other 3A4 drugs.
Okay, subtle but important distinction. Now, voriconazole, the go-to for Aspergillus.
Correct. Voriconazole is now considered the drug of choice for invasive aspergillosis, generally preferred over Amphotericin B. Also great for invasive candida, Cetosporium, Fusarium. It has good oral bioavailability, gets into the CSF. But its PK, it's probably the most complex of all.
Complex in what way?
Right.
Multiple enzymes involved. Yes, it's heavily metabolized by three major CYPs, 2C19, 2C9, and 3A4. And the big challenge is its nonlinear kinetics. Nonlinear meaning doubling the dose doesn't just double the drug level.
Exactly. The relationship isn't proportional. Small dose increases can lead to unexpectedly large jumps in drug concentration because the metabolic enzymes get saturated quickly. And this is hugely complicated by genetic variation.
Pharmacogenetics.
Yes, especially in the CYP2C19 enzyme. People metabolize voriconazole at very different rates depending on their genetics: poor, intermediate, extensive, or even ultra-rapid metabolizers.
Sounds like a drug where you absolutely need to measure levels. Therapeutic drug monitoring, TDM, highly recommended, yes. You need to ensure it's working, but avoid toxicity. High levels are linked to distinct side effects: visual disturbances, blurry vision, changes in color perception, and even auditory hallucinations. Plus, significant liver toxicity risk. And being involved with 2C19, 2C9, and 3A4 means its potential for drug interactions is massive.
Effective, but very tricky PK. Finally, the newest one, isovuconazole. It's a prodrug.
Yes, isovuconazole is given as isovuconazonium, a prodrug that's quickly chopped up by enzymes in the blood, esterases, to release the active drug. Its spectrum is similar to voriconazole, and it's approved for invasive aspergillosis and invasive mucormycosis.
How does its PK compare?
It has good bioavailability. It's metabolized mainly by CYP3A45 and also UGT glucuronidation. And like the others, it's a potent inhibitor of CYP3A4 itself, so you still need to be vigilant about those interactions. Maybe slightly cleaner PK than voriconazole, but the 3A4 inhibition risk remains. All right, we've navigated the membrane attackers and the ergosterol synthesis blockers with all their CYP complexities. Now we move to a newer, and you hinted, safer class, the Echinocandins. The cell wall warriors. Yes, this class was a real breakthrough. They target something truly unique to fungi, that cell wall structure we talked about earlier. This gives them amazing selectivity and a much better safety profile generally.
And their mechanism, how do they hit the wall?
They inhibit an enzyme called beta-blotte-3-glucan synthase. This enzyme is essential for making beta-artonoglucan, which is a major structural component, like a key building block, of the fungal cell wall.
So block the building block.
And the wall loses its integrity, it becomes weak, can't withstand osmotic pressure, and the fungal cell basically it bursts. So they are generally fungicidal.
A fungicidal mechanism hitting a target we don't have. Sounds ideal. Which drugs are in this class?
The main ones are caspofungin, mycofungin, and anidulafungin. All of them have to be given intravenously, IV only.
And their main role clinically. Where do they shine? They are really potent against Aspergillus and most Candida species, and here's the key clinical pearl. They often work even against Candida strains that have become resistant to azoles. This makes them incredibly valuable, especially for treating candidemia, bloodstream Candida infections. Azole-resistant Candida, that's a growing problem.
It is. So Echinocandins are often first-line therapy now for those serious Candida infections, but important limitation. They don't work well against Cryptococcus or the Zygomycetes.
Okay, now the big selling point you mentioned earlier, their pharmacokinetics and safety, especially regarding interactions.
This is why they're often called the clean slate drugs. Compared to the azoles, their interaction profile is remarkably clean. Why? Because they are not significantly metabolized by the CYP450 system.
Ah, no CYP involvement. That avoids all those interaction headaches we just discussed with azoles.
Exactly. It means you can often use them much more safely in complex patients who are already on multiple drugs that interact with CYPs, like transplant patients on immunosuppressants. Minimal drug interactions is their huge advantage.
Are there any dosing things to know or side effects?
They're generally very well tolerated. The main thing is they need to be infused slowly over about an hour to avoid histamine release reactions, things like flushing, maybe mild itching.
Like a milder version of the Ampho B infusion reaction?
Much, much milder, yeah. Just needs a slow infusion. Dosing-wise, caspofungin is slightly different. It needs a loading dose on day 1, and the dose might need adjusting if the patient has moderate liver problems. Mycofungin and anidulafungin are a bit simpler. Mycofungin, for instance, doesn't need a loading dose, but overall a very safe class, relatively speaking. #tag B. Agents for dermatophyte infections, tinea and onychomycosis.
Okay, we've covered the systemic big guns. Now let's pivot to the drugs used mainly for skin and nail fungal infections, the dermatophytes causing tinea, like athlete's foot ringworm, and on acomycosis, nail fungus. We're going back to targeting ergosterol synthesis, but with a different class.
Right, the squalene epoxidase inhibitors. The main player here is terbinafine. They hit the ergosterol pathway, but earlier than the azoles do.
How does their mechanism work inhibiting squalene epoxidase?
Yes, they block that enzyme. Like the azoles, this stops ergosterol from being made, but the consequence is different. Blocking squalene epoxidase leads to a buildup of the precursor molecule, squalene, inside the fungal cell. And high levels of squalene are actually toxic to the fungus. It disrupts the cell membrane and kills the cell. So terbinafine is considered fungicidal.
Interesting. So blocking the pathway causes a toxic buildup. And terbinafine is the top choice for nail fungus on acomycosis.
Yes, oral terbinafine is generally the drug of choice for dermatophyte nail infections. It concentrates well in skin and nails. And a big advantage over older drugs like griseofulvin is that it usually works faster, maybe 3 months for fingernails, a bit longer for toenails, compared to 6 or 12 months potentially.
That's a huge difference in treatment duration.
It really is. Terbinafine is also used topically for simpler skin tinnias and sometimes orally for tinea capitis, scalp fungus, if topical stuff isn't working.
Does terbinafine have the same kind of CYP interaction risks as the azoles?
This is another key distinction. It does interact with CYPs, but a different one. Terbinafine is a significant inhibitor of CYP450 2D6.
2D6. That metabolizes different drugs than 3A4, right? Like some antidepressants, beta blockers.
Exactly. Things like certain SSRIs, tricyclic antidepressants, some beta blockers, codeine. So while you avoid the 3A4 mess of the azoles, you absolutely have to be aware of potential interactions with drugs handled by 2D6. Side effect-wise, besides some GI upset, the notable ones are potential taste disturbances. Sometimes they don't go away, and occasional visual changes.
Taste disturbance. That's an odd one. Okay, what about the older drug, griseofulvin? It targets something completely different.
Yeah, griseofulvin has a unique mechanism among antifungals. It's primarily fungistatic. It gets into newly formed skin and nail cells and works by disrupting the mitotic spindle inside the fungal cells that are trying to infect those tissues.
Mitotic spindle. So it stops the fungus from dividing, inhibits mitosis.
Precisely. While terbinafine is generally preferred now for nails due to shorter treatment times, griseofulvin is still used, especially for tinea capitis in kids.
And its PK and interactions. Well, treatment takes a long time because you have to wait for the infected nail or hair to grow out completely. Absorption is much better if you take it with a fatty meal. That's a classic counseling point. And interaction-wise, griseofulvin is the opposite of most azoles. It's a CYP450 inducer. An inducer, so it speeds up the metabolism of other drugs.
Yes. It can make other drugs like warfarin or oral contraceptives less effective because they get broken down faster. That requires careful monitoring and dose adjustments. And it's absolutely contraindicated in pregnancy and in patients with porphyria.
Okay, inducer versus inhibitor, another key difference. Let's quickly cover nystatin and the topical options. Nystatin's role.
Nystatin is another polyene structurally and mechanistically similar to Amphotericin B forms pores, but it's basically not absorbed from the gut and way too toxic to ever use systemically. So its use is limited entirely to topical applications for candida.
Like oral thrush or vaginal yeast infections.
Exactly. The classic swish and swallow or swish and spit for oral thrush or cream suppositories for vaginal candidiasis, that's its niche.
And the mini topical imidazoles. Clotrimazole, mycoses.
Yeah, those are mainstays for treating superficial tinea infections, athlete's foot, jock itch, ringworm, and localized candida skin infections. Very effective topically. And this reminds us of an important safety point about ketoconazole.
The imidazole that used to be systemic.
Right. Oral ketoconazole is almost never used systemically anymore because of the high risk of severe liver injury and problems with adrenal hormone production. We have much safer systemic options now, like the triazoles. Shows how the field evolves towards better safety.
Good point. And finally, there's a whole bunch of newer specialized topical agents, mainly for nail fungus, right? Must be tough to treat.
Oronical mycosis is definitely stubborn, so we have things like echinocandins, a topical triazole solution, but it takes a long time, 48 weeks of treatment. Cyclopirox is interesting. It's a pyridine antimycotic with a different mechanism, messing with nutrient transport, and comes as a nail lacquer or shampoo.
A nail lacquer, like polish.
Yeah.
Yeah. Then there's tavabarol, another topical solution, also 48 weeks, that inhibits fungal protein synthesis by blocking an enzyme called aminoacyl tRNA synthetase. Tolnaftate, that's an older one, a thiocarb major, often found over the counter. It distorts fungal growth. But the key thing about tolnaftate, it works for tinnias, but not effective against candida. That's essentially, yeah. Then there's tavabarol, another topical solution, also 48 weeks, that inhibits fungal protein synthesis by blocking an enzyme called aminoacyl tRNA synthetase. Tolnaftate, that's an older one, a thiocarbamate, often found over the counter. It distorts fungal growth. But the key thing about tolnaftate, hashtag tag out outro. Okay, that was an incredibly dense journey through antifungal pharmacology. Let's try to synthesize this. Pull out the core connections between the drugs and their targets to really lock it in.
Yeah.
Boiling it down helps. Think about the target. Yeah, boiling it down helps. Think about the target. One is the finished membrane itself. That's the polyenes Ampho B, nystatin. Direct interruption, pore formation. Very effective, but potential for high toxicity. Okay, membrane integrity.
2. Is it making the ergosterol for the membrane, that's the azoles, blocking 14-alpha-demethylase high CYP interaction risk, especially 3A4, and the squalene epoxidase inhibitors like terbinafine, blocking earlier, causing squalene buildup, watch out for CYP2D6 inhibition.
Ergosterol synthesis pathway.
Got it. 3. Is it the cell wall structure? That's the Echinocandins, inhibiting beta 1,3,2-ida-glucan synthesis, unique fungal target, fungicidal, minimal interactions, the clean slate.
Cell wall. the safe harbor interaction-wise.
Is it nucleic acid synthesis? That's flucytosine, using that fungal-specific permease enzyme to get inside and mess things up, but always used in combination, usually with Ampho B.
Okay, that target-based summary is really helpful. But you emphasize throughout that true mastery isn't just the MOA, it's mastering the pharmacokinetics, especially those interactions.
Absolutely. Knowing the MOA is step one. Level 2, the mastery level, is deeply understanding the PK. The choice between, say, voriconazole and micafungin for a complex patient often comes down entirely to that patient's other medications and the interaction risk profile.
So knowing voricanazole's complex, nonlinear, multi-CYP metabolism versus mycofungin's clean, non-CYP profile, that's the clinical decision point.
Precisely. It's about managing risk. Can you handle the intense monitoring and interaction screening needed for voriconazole? Or is the Echinocandin the much safer path for this particular patient? That differential risk assessment is clinical expertise in this area.
We saw how drug resistance and toxicity pushed innovation towards the Echinocandins, targeting the cell wall's glucan synthesis. It makes you wonder, what's next?
Yeah, that's the forward-looking question for anyone wanting real mastery. We found a great target in the cell wall, outside the main CYP pathways. What other essential fungal process, something vital but unique to fungi, could be the next breakthrough target?
Something beyond glucan, beyond sterols, beyond the current CYPs.
Maybe a specific fungal nutrient transporter, a unique enzyme in a metabolic pathway we haven't exploited, part of the fungal ribosome that's different enough. Finding that next novel Achilles heel, especially one that avoids the common interaction pathways, that's the ongoing challenge that could really redefine antifungal therapy again.
A fantastic thought to wrap things up. Really pushes us to think about the future of tackling these tough infections. Thank you for guiding us through this incredibly complex but vital area. And thank you for joining us on the deep dive. Hopefully you now feel equipped to approach antifungal pharmacology with more confidence and the necessary caution these powerful drugs demand.